Good afternoon, everyone. My name is Molly Gray. I serve as Vermont's 82nd Lieutenant Governor, and it's my absolute pleasure to welcome you all to our second of a series of Seat at the Table events. I know we've got lots of folks logging in right now, so we'll just give everyone a moment to get logged in and to get settled. Thank you again for joining us. And I will mention before we start that this discussion is recorded, and we will have plenty of time for questions from all of you at the end and after hearing from our incredible lineup of panelists. So again, thank you for joining us. It looks like we've got everyone on the call. So welcome to our second Seat at the Table. This event is really focused on, and again, we're hosting it bi-weekly, elevating the voices of Vermonters in the State House, giving a voice to individuals who sometimes aren't in the building. And as we all know right now, we're operating in a virtual State House. So this is a particularly important topic today. And again, I just want to recall that this event will be recorded so you can share it with colleagues and friends after. We'll keep things to about an hour. So we'll finish up around 1:30. And before I introduce our speakers, I want to recognize some administration officials and legislators who are here today. I believe Susanna Davis is with us, and also Karen Dolan from the Vermont Department of Health, individuals who have been really working at the forefront to address equity and also access to public health over the last year. So today's focus is equity in public health, and specifically with regards individuals who have a refugee background in Vermont. And before introducing our speakers, I just want to frame up why we chose this issue and why we believe right now it's such an important one, and why our speakers and their views are really critical to Vermont's future. So first, I'd like to talk about what's happening nationally. President Obama on February 4th signed an executive order launching a new set of priorities for Vermont and the United States with regards to refugee resettlement. Over the last year, refugee resettlement nationally has dropped to a cap of 15,000, which is the lowest ever since the 1980 Refugee Convention was signed and adopted by the United States and Vermont, and the United States took action. And the president has now raised that cap to 125,000. Which is incredibly important. So not only is Vermont poised, but the nation is poised to accept more refugees. And Vermont historically is known for being a sanctuary state, Burlington in particular, a state where we have a large refugee or former refugee population, and have really benefited from the leadership of Senator Patrick Leahy. And finally, I just want to briefly touch on what we all know about our state, which is that we have a declining population. We suffer from a demographic crisis. We are one of the least diverse states in the country. So as we begin today, I'd like to just invite us all to think about and consider, if we're going to move forward in growing our population, if we're going to go forward in being a more diverse and welcoming state, how do we ensure that we address issues like equity in public health as we move forward? So with that, I'd like to introduce our incredible lineup of speakers. Dr. Maria Mercedes Avila, who is an associate professor of pediatrics at the University of Vermont. Amila Merdzanovic, director of the U.S. Committee for Refugees and Immigrants for Vermont. Dr. Jules Wetchi, who is a public health specialist speaking on behalf of and giving voice to some of the new American or former refugee community in Vermont. Dr. Pablo Bose, who's the Associate Professor of Geography and a Director of Global Studies at the University of Vermont, and Tato Ratsibi, who's the Associate Director and Programs Manager for the Association of Africans Living in Vermont. So to begin today's discussion, I'd like to pose sort of an open-ended question for each of our panelists. As we know, COVID-19 has laid everything bare, in particular inequities within our public health and healthcare system. Equity in accessing information and resources related to COVID-19 in particular. Can you talk about your work, the work of your organizations, how you've seen these inequities manifest particularly within the former refugee community here in the state. Dr. Avila, we'll begin with you.
Thank you, Lieutenant Governor Gray, for having us today, and thank you for focusing on this important topic. I would like to start by sharing that I have been working with former refugee and immigrant communities for almost 2 decades in Vermont, but in no way I consider myself an expert on these communities or I speak for them. I share my knowledge and professional and personal experience as a Latina immigrant and health equity scholar in hopes that the stories, research, and information that I share help raise awareness in our communities towards addressing and eliminating racial and health disparities. If there is one takeaway message for the public to leave this presentation with, it is to understand that no one can ever be an expert of someone else's story, and no one can ever be an expert on someone else's experience or lived experience or question these experiences. One important aspect of the work that I've been doing in Vermont is emphasizing that we have to work with communities. Historically, and I work in academia, historically, we have worked in communities. However, the work should happen with communities. Working with communities means that we have to actively support underserved and unserved communities, engage in meaningful work with them, and partner with communities and community service organizations from the planning, implementation, and evaluation of projects. We also have to ensure that all communities have access to opportunities, programs, and services in equitable ways. And this means, for example, ensuring information is translated in different languages. Interpretation services are available to communities who are limited English proficient, and following always state and federal law. This is language access issues is one of the most often problem that I have encountered in the state of Vermont. That was also one of the issues connected to some of the outbreaks in the state. We also need to ensure that funding for programs is allocated equitably across communities and based on need and specific disparities and inequities we are identifying. When we create plans, for example, for a pandemic like is happening right now with COVID-19, we need to ensure that information is reaching communities in real time. And that was one of the main issues connected to the outbreak, that information originally did not reach communities in a timely manner. Although now there are many initiatives to address some of these gaps that happened at the beginning, we have to continue to remind ourselves the importance of language access and real-time information and interpretation and translation services. At the beginning, there was a lot of confusion around stigma, around testing results, isolation, quarantine, and even vaccine concerns that we were able to address through different initiatives. One of them is community outreach and education is one of the key aspects of doing this work. All of this is part of health equity. And to close this specific section, I would say we need to work and implement best practice models, guidelines, and research related to health equity. One of them is using social determinants of health frameworks. We know that these frameworks include an area which is a key aspect of social determinants of health that is called social norms and attitudes. Within this social determinant of health, we find exposure to discrimination, racism, and distrust of the government is one of the key aspects that is leading communities to having higher chronic health problems and experiencing health disparities. Research also shows that even when we account for income and access to healthcare, we still find disparities in racially diverse communities. So this speaks to the systemic nature of racism in the US, including in a predominantly white state like Vermont. So we must actively work towards removing barriers to quality health and healthcare, and we must also actively work towards dismantling systemic institutionalized structural racism from our society. Thank you for that question.
Thank you, Doctor. And I know you've been working around the clock. I know earlier we were speaking about the clinics that you've been helping to run, the trainings you've been offering. So just thank you again for taking time to join us today. Amila, we'd next like to hear from you, and on behalf of USCRI, I know you've been doing incredible work to resettle refugees for years and years here in Vermont. So welcome and thank you.
Good afternoon, Lieutenant Governor Gray. Thank you so much for convening this wonderful meeting and for giving us this opportunity to talk about the important work that we've been doing over the last year, but also more broadly around refugee resettlement and the impact of refugee resettlement on the economy and the vitality of the state. And also to together feel hopeful and look to the future as we gear up for welcoming new refugee families into the state. As you mentioned, the incoming Biden administration has raised the refugee ceiling, the number of refugee arrivals that will be welcomed in the current fiscal year from 15,000 to 62,500. The originally, when they were in the fall and early, December, the number was 125,000. And now that they have come into the office and actually understood that a lot of the infrastructure, both nationally and globally, has been dismantled, that number was set at a more realistic figure of 62,500 refugees and 10,000 SIVs, or special immigrant visa holders, which are nationals of Iraq and Afghanistan who have supported our government overseas in some capacity and have been given a promise of resettlement to the United States in order to ensure their safety and reward their service to our government. So just a quick note about myself. I was resettled as refugee in '95 from Bosnia, and I'm the first former refugee to lead the refugee resettlement program, hopefully not the last. We have been, the refugee resettlement program is still known as the Vermont Refugee Resettlement Program, but our official name is the U.S. Committee for Refugees and Immigrants, or USCRI Vermont. We have been around since the 80s, and according to our data, which actually only dates back to 1989, we have welcomed about 8,000 refugees who have arrived through the Federal Refugee Resettlement Program. And I'll name from all corners of the globe, and I'll name just a few countries: Burma, Bhutan, Bosnia, Kosovo, Iraq, Rwanda, Sudan, Somalia, Syria, and others. Democratic Republic of Congo, Congo-Brazzaville, and others. As you mentioned, Lieutenant Governor, over the past 4 years, the refugee resettlement has suffered greatly, and that infrastructure, as I mentioned, both nationally and globally, has been bruised and dismantled in many respects. So prior to 2017, we, as the Refugee Resettlement Program, were welcoming about 325 to 350 individuals per year. In 2017, that number dropped down to about 200. The following year, about 130. And then last year, which was the last year of a previous administration, that number dropped to 23 individuals for the year. We have also important to mention, on average, through the Refugee Resettlement Program, about 200 employable adults came into the state. So when we talk about the impacts of refugee resettlement, we have to remember that through the refugee resettlement route, I don't like to use the word pipeline, about 200 employable adults entered the state and went to work. The Refugee Resettlement Program it's a federal program, and the focus is on early employment and early economic self-sufficiency. We are a sort of a one-stop shop. We provide case management support starting even before a family arrives. We secure housing, provide basic household necessities. We assist families to connect with healthcare, school. We provide employment support, health, case management, education, interpretation, translation, and other wraparound services. Refugee resettlement cannot be done in the vacuum, is not done in the vacuum. We work very closely in partnership with State Refugee Office, Vermont Department of Health, and other state offices. Also our sister agency, Association of Africans Living in Vermont. We touch a lot of the same families, I would say 90% probably, and coordinate efforts. Since the pandemic, as Dr. Avila mentioned, I will just mention one aspect of our work. Our work shifted from welcoming new arrivals and helping them, settle, to responding to the critical needs. Many families still to this day are being impacted by COVID-19, loss of employment, food insecurity, housing insecurity. So our direct services staff work shifted from, their regular day jobs to responding to the critical needs. Also, in terms of equity, as Dr. Avila mentioned, the information initially around COVID-19, everything and anything related to COVID-19, and the supports available in the community was not getting to different communities, LEP communities, in a timely manner or linguistically and culturally appropriate manner. So a group was started. It really was started by two people. A video was recorded in Somali. Our colleague Alison Seeger and Mohammed Jafar recorded a video in Somali. And from there, it grew to be known as the Multilingual Task Force. We have now put out over 400 videos and voice recordings in 14 different languages, which the last one, the facts about COVID-19 vaccine, has reached over 3,000 individuals. So our work continues. It has recently shifted to, I would say there's parallel tracks. There's still families who are being impacted by COVID, and then the vaccine rollout. So outreach, education, and recruitment, and the support to the vaccine clinics.
Thank you. Thank you so much. I look forward to coming back to you with our next question on sort of where do we go from here? But it's my pleasure now to also introduce another speaker, Dr. Jules Wetchi, who is a certified doctor in the Democratic Republic of Congo and received his master's in public health from the University of Vermont. Dr. Wetchi, welcome.
Thank you. Good afternoon. Bonjour, bon après-midi. I'd like to thank the Lieutenant Governor Molly for giving me the opportunity to participate in the seat at the table on equity in public health access. Thank you so much. I come before you this afternoon as a leader and public health specialist representing Vermont's New American community in the seat at the table. I said that the inequity we see during this time of COVID-19 is a drop in the ocean. My personal experience as an immigrant and public health specialist, the inequity in general is due to the complexity of the healthcare delivery system in the United States, which causes health disparities in minority communities. The major problem found in the United States care delivery systems is complicated question, said Bernard and Tina Murray Evans in Introduction to Healthcare Services, Foundation and Challenges. The answer depends on the biases of the group you are talking to. Physicians blame insurance providers blame employer, employees fault government regulation, and the consumers of health services blame everyone. The healthcare delivery system in the United States is a crisis situation that threatens its long-term survival. The healthcare system is complex. Government, as I said, providers, insurance, and pharmaceutical companies. At the hospital, what we see. A lot of paper to fill out. Long waiting time. Prescription for everything. the lack of cultural competency, miscommunication, quick decisions, the barrier of language. According to the global perspective of health equity and COVID-19, the COVID-19 is disproportionately affecting the poor, minorities, and a broad range of vulnerable population due to its inequitable spread in areas of dense population and limited mitigation capacity due to high prevalence of chronic conditions or poor access to high quality public health and medical care. My community as a culture broker, I saw the barrier language for worship, and I did create what they call the French-speaking African Catholic community. And once a month, we have French Mass. It helps people to worship well. And in our Mass, we are able to sing in Swahili because most of immigrants here, they speak Swahili, Kikongo, Chiluba, and Lingala, also in French. And during this period of COVID-19, the lack of effective communication pushed me to create 2 broadcast shows in radio community of Burlington. One we call African Variety Show, which is a center on the integration of New American. We are defending our cultural values. We are presenting our cultural diversity in several areas: education, health, public health, and culture. So during the African Variety Show, I try myself to relate the message from COVID-19 for many languages, Swahili, because myself I speak Swahili, French, Lingala, Kikongo. And also the second broadcast I called Saturday morning. It's the preparation for the worship of Sunday to help immigrants to pray well, because the Mass here in the English, people, they cannot listen nothing in English. So during the show, I try to prepare them for worship, and also I included all information, all materials of COVID-19. I try to educate people because education in public health is very important. The good, effective communication, it's very important to give a good result. And also as a culture broker, I try to help medical students at UVM at the program they call Global Health. So I'm doing a Global Health bridge. So I try to teach, to share my expertise with the future students, how they can improve, they can understand, they can have a cultural humility to learn all the culture and improving the approach facing the New American.
Thank you. Thank you, Doctor, so much for your time. And also recognizing that we're doing today's conversation in English, and appreciate you being willing to speak in English with us today. Also your radio show, that's incredible. And I look forward to asking you more about that and the work that you've done to share information through the radio during this challenging time. But I want to introduce our next speaker, Dr. Pablo Bose, the Associate Professor of Geography and the Director of Global Studies at the University of Vermont, who I know is working on a recent book and has been speaking regularly about changes at the national level and what this means for Vermont. Dr. Bose, welcome.
Thank you for having me on this panel, Lieutenant Governor Gray. I'm not going to repeat what a number of the panelists have said already. I'm really glad they've provided some of that background and context. I've also had the great pleasure of working with USCRI and ALV for about 12 years now, looking at a number of different aspects of resettlement, as well as at the national level. And we've heard a number of people, sort of make the comment about COVID-19 and this pandemic as not necessarily just causing a crisis, but exacerbating many of the vulnerabilities that were already present. And I think that's something that's been once again made very clear when you look at what's been going on here. I'll just talk about a couple of things specifically that I've been working on in relation to the COVID-19 pandemic and its impact on resettled communities here in Vermont. I've been looking at a number of these different kinds of impacts. And as I said before, I've looked at the ways in which access to transportation, housing, healthcare, employment, education, all of these things have a clear impact on outcomes. But most recently, I've been working on a couple of different studies with ALV and with the food bank, for example. We began to look at the issue of food insecurity. So I'll mention a couple of these studies that I started doing at the outset of the pandemic. So as a number of the panelists here mentioned, you know, the particular impact on families was apparent right off the bat. And, you know, I want to give a lot of credit here to ALV, to USCRI, to the state, a number of different organizations that came together to provide all manner of help. There was all kinds of triaging of efforts for short term, you know, what is the impact for those families and communities that were, you know, affected by an outbreak, who were affected by loss of work as the lockdowns went into effect, a whole range of kind of cascading effects. And amongst the different things that were sort of put in place were different forms of emergency services. So one of those was food deliveries, amongst other kinds of deliveries. And so I, in conjunction with the food bank and some other partners, the Family Room and others, began to look at the effectiveness of some of these deliveries. And so that was really interesting to see where off the bat, these food deliveries were being provided, but as the surveys that we did with the communities who were receiving these deliveries, once again, those questions of communication and language and really different kinds of cultural competencies, as Dr. Wetchi described, came to the fore. We saw that people were receiving food, but sometimes it wasn't culturally preferred food or food that people were familiar with, or, you know, other kinds of things. And so the food bank began to work with Digger's Mirth and the Intervale to provide, you know, fresh food, veggie food boxes and things like that. And so we've done a number of studies to kind of look at how those deliveries are going. And really the longer term goal here is to work with food support organizations like the food bank to provide more culturally preferred food in the long run, not just in the context of a pandemic. Similarly, we did another survey. So in both of these surveys, about 200 respondents looking at the impact of telemedicine and telehealth access. So there we were working with the New Americans Pediatrics Clinic and Dr. Andrea Green to look at everything from technology access and then what the experience of making a appointment was, what the experience of doing a telehealth appointment with a doctor was, all of these different aspects of it. So again, those are two surveys that I'm in the midst of just finishing up the analysis of. Another interesting study that we did with USCRI and actually it was USCRI and ALV really taking the lead on looking at childcare, the impacts on childcare, and also the potential for community-based childcare provision as well. So just to say that there's some really interesting work that's going on to try and provide interventions to address with some of these crises, but it's, I mean, I have to say that having worked in a lot of other kinds of contexts than Vermont, I think we are incredibly lucky to have organizations like USCRI and ALV. And I don't think that I worry sometimes we take them for granted. And the ways in which we might support them, I think, could really be expanded, because I honestly don't know where we would be without these organizations. Thank you.
Thank you, Doctor. I think that's such an important recognition. And I'm going to come back to you in a moment with a second question on specifically what can we do to build on some of the success of these different surveys. I did want to ask, for those listening who might want to access that data once it becomes available, when will it be available? When do we expect to see it? And where can we get it?
I owe reports to Tato and Amila. So as soon as I get those reports out to them, they will be posted. There will be public reports posted very shortly.
Great. Sorry to put you in the hot seat, but data is king, as you know. I look forward to, and we'd be very happy to review and share that information once it's available. AALV, where would we be without AALV and all of the incredible work of Tato? Tato, it's such a pleasure to welcome you today. Thank you so much for your time. I know you've been working around the clock. Would love to hear from you on this question of what are the needs and what has the last year exposed, particularly for you and the communities you support. Thank you so much for being here.
Thank you, Lieutenant Governor Gray, for having me. I have to say right away that I wish I could take the credit of the work. I have incredible staff that does this work without complaining, dedication, selflessness, and just being there to serve the communities. So I have to say that under the leadership of Jacob, we are very, very lucky to be where we are. To start my conversation, I just would like to give an overview of what AALV is as an organization. We are an existing organization that's not well known, and that's partly because we just don't do a good job to say that we are here. We are consumed in our work all the time. So AALV started in 2000 as a community-based organization. Over the years, as the refugee resettlement increased, the organization grew, and we provide case management services and referral services to other organizations who serve clients who primarily have language needs. So we are a staff of 18 from 12 different countries. So if you ever want to go to the United Nations, there's mini UN right here in Vermont between all our organizations. So we have the pleasure really to serve folks who have chosen Vermont as their second home by helping, by having them help guide how they need our services. Our model of services is clients coming in, identifying what it is that they need, and us just being a support to provide services. So we are very lucky to be in the position that we are in. With COVID-19, I have to say that my fellow presenters have covered a lot of the gaps that we all identified. And I have to say that the gaps that either magnified the global and local challenges that have existed around public health, and also the reality that the pandemic hit and we were all not prepared. So I always say that we have to be in a position to be compassionate as we do this work. We cannot do this work without compassion. That said, we had to adapt the way we work with our community right away. The shutdown happened and we had to figure ways of quickly providing services in ways that we have never done. That meant adapting, from the ability to have the communities access our doors whenever they needed to without appointments, to now moving to telephonic services until we were able to figure out how to safely do home visits. We didn't have the luxury nor the option to completely shut down during the shutdown. We still did home visits. We had to because people were isolated in a new place and didn't really have enough information as to why that was happening. So we had to find creative ways of sharing information. And one of the ways, as Amila mentioned, was to start this multilingual task force. We also had to switch to providing services for some of the group work that we do through Zoom, for example. I have to say that most of our communities are now very familiar and comfortable with technology, thanks to the schools, because the school closed, the kids were home, and they actually helped a lot in helping parents know how to access Zoom. Obviously this has, in a way, I want to focus on some of the good things that actually happened out of this situation, and then talk a little bit about what we can do to strengthen what happened. I think when COVID-19 happened, we all saw the gaps, but it also forced all of us to work together, because that was the only way we are going to provide adequate services to the communities. Working in silos never work. We are such a small state, and we all do the work. So we're quickly able to identify how we can all come together to support our communities, to provide interpreter services at the pop-up centers, that testing centers, that through the collaboration with Vermont Department of Health, we were able to do so. It took a lot of advocacy. I have to mention that some of the work that we do, without advocates from the community speaking up, it cannot happen. But it also finds willing partners on the ground who are simply saying, how can we do this together? So Vermont Department of Health stepped up big time. We were able to set up testing centers in places where clients can easily access those by walking, by public transportation. We also, that actually gave an opportunity that when the vaccine rolled out, we were able to set up a similar arrangement, which works well for our communities. We also worked very closely with the Vermont Department of Labor. I have to give them the credit for working really hard to figuring out how we can support our folks who couldn't access technology and depended on us as case managers to apply for unemployment. Department of Labor was able to create a system where we can actually talk to people to troubleshoot when we're experiencing some challenges with applications. So I just mentioned this too, but there are other many organizations and departments that worked very closely with us to provide services. The Economic Services Division, we're able to work ways that we could help our clients or our communities to access services. That also showed that we really have to have a setup that is accommodating to all the communities ahead of time, prior to crisis happening. I think it was a good lesson to all of us to think about how can we prepare now that we know we are expecting more people to become our new neighbors. We have to be thinking critically about, now that we have these lessons that we learned, how do we apply them to prepare for better resettlement? There's no way about it. Public health is human rights. And an unhealthy community is the community that doesn't thrive. So we have to figure out to set up systems that are going to help all the communities thrive in Vermont. So I think I will say that much for now, and we'll add as we continue. Thank you for the opportunity.
Thank you. Thank you so much. And for also bringing a bit of positivity to a conversation during a really tough time, and for all of your work. I also, before we come back to with the second question about what comes next, I want to recognize a few of the officials here. We have representatives from the Department of Public Health, and I want to recognize their work. Also a representative from Congressman Welch's office. I believe Thafine is here. So thank you to everyone joining us today. I want to come back to the question of where do we go from here? Sort of this, if, you know, we've identified a lot of the need in the first part of today's conversation, but if we're going to, as I said, be a state that is diverse, that's welcoming, that's prepared for a growth in refugee resettlement, but a state that really puts equity at the forefront in accessing food through different programs, and accessing telemedicine or remote work, online learning. We talked about broadband in our last seat at the table, but specifically public health. If there were 4 things or 5 things or 3 things from our panelists' perspective that you would want policymakers to hear today, what would they be? And I'm going to ask that we keep it quick, we keep it short and very specific, just so we have enough time to get to questions and answers in our remaining 15 minutes. So Dr. Avila, I'm going to come back to you. What do we need to do?
And thank you for that question. That's one of my favorite questions always, because there is a lot to do around health equity. One of the topics I always share when I do presentations and when I do health equity work is to ensure that states require ongoing professional development and training as one of the most effective ways of reducing health disparities. And this work includes structural competency, cultural humility, racial equity training. Sometimes people are confused about the definition of ongoing education and training. So I want to clarify that. I'm not talking about, forwarding emails of webinars, sharing links on the website, or creating diversity committees. I'm talking about meaningful work around dismantling systemic oppression and meaningful work around allocation of resources to support this work. Having worked with many organizations and done hundreds of presentations around these topics and around the country, I can share that the biggest knowledge gaps that my research has identified with health and allied health providers is not knowing the history of this country, not knowing how this country was founded, and not knowing the history of racial disparities and how these racial disparities intersect directly with health disparities. This lack of knowledge related to the root causes of today's disparities has caused many people to not understand what is currently happening in the US with COVID-19 racial disparities. COVID-19 has resurfaced many issues that have existed for a long time in the United States, but when you have a public health emergency, an issue like COVID-19, you start seeing these issues resurface, and racial disparities is one of them. I think the second topic is to enroll more providers to work with underserved populations. We need, right now, for example, I coordinate an initiative with cultural brokers, and this cultural brokering program has reached out to almost 4,000 community members related to substance abuse and mental health screening. We need to expand work related to community health workers, cultural brokers. Community outreach work is one of the most effective models in bridging the cultural divide that might exist between an organization that might not be completely trusted by communities and the communities that we're trying to serve. Having community leaders from those communities that we want to work with, making that link. We also need to hire, train, retain, and promote bilingual, bicultural providers. We need to ensure our programs in our universities, in our state colleges, focus on recruitment of local talent that we have in our areas for all programs related to health and allied health. I go to so many meetings and advocate so often to have more students in nursing, more students in medical school, and all allied health programs to make sure that the workforce represents the communities that we serve. Is one of the most effective ways in addressing and eliminating health disparities, ensuring that all workforce, every workforce, whether it's health or allied health, teachers, any area reflects the population that we serve. As you know, most of the refugee resettlement and immigrant populations are most often in the Chittenden area, and we know that Burlington and Winooski are two of the most diverse cities. Actually, Winooski is the most diverse city that we have right now. I was looking at the statistics last night, and what research shows is that we need to reflect the demographics of the communities. For example, Winooski right now is 75% white and non-Hispanic. It means that all organizations should have 25% racial diversity reflected in every organization and every program that we have in that area. So that's one example. The next topic, which is the last one related to recommendations, is establishing advisory groups that also represent the communities that we served and provide oversight for grants, projects, and funding in the state. I founded in 2015 the Health Disparities and Cultural Competency Advisory Group, which is funded through the Department of Health and through other federal grants. And the group is 95% racially diverse, representing many different groups across the state. The group supports many programs and has been selected as the 2020 Diversity Team awardee by the National Diversity Journal because of our work connecting to social determinants of health. So as you can see, there is a lot we can do to ensure all communities can thrive in our society. We have to meaningfully and actively engage in dismantling systemic oppression, racism, classism, ableism, heterosexism, and many other forms of prejudice and discrimination. We also have to educate ourselves. I started this the first question sharing that I don't consider myself an expert, but a lifelong learner. Being culturally responsive means that we had to engage in ongoing education and training and self-reflection and critical reflection about structural competency, cultural humility, health equity, social determinants of health. All of this work is a lifelong journey and not a destination. So there's still a lot of work ahead of us and many unmet needs in our most vulnerable communities. So I hope everybody understands the importance of engaging in learning and the healing that we had to do, that we have ahead of us. Thank you for this opportunity.
Thank you. And Dr. Before I let you off of the hot seat, if there is a place that individuals want to go to basically draw on some of the information that you shared today, would you mind sharing in the chat either your website or resources that might be available based on what you've shared?
Absolutely, and I can share my email on the link, and anybody can email me. I can refer them to any.
Busy, but thank you. Amila, let's hear from you and the USCRIVT or the Vermont Refugee Resettlement Program perspective. What do you need? How can we help? How can policymakers and the state help?
Thank you so much. I'm only laughing because do you really want to know? Because we need a lot. I'm kidding. As we look to rebuild, I will just mention that prior to 2017, we were 19 staff and we're down to 12 full-time. And this loss in staffing is a reflection of loss in funding. The majority of our funding is federal funding, and over the past 4 years was drastically cut. So as we look to welcome more refugees into the state, my priority is to rebuild some of the lost infrastructure here in Chittenden County to be able to welcome new families. Since the pandemic, we stopped taking in-kind donations of household goods. However, we will be resuming that in the coming month or so. So our community, I always say our community is the backbone of everything we do, and we couldn't do refugee resettlement in the way we have done it over the past 40 years if it wasn't for the support of the community, both in terms of in-kind donations, financial contributions, volunteer support. So on our website is under construction. I can put my contacts in the chat, and community members can reach out directly. Also, I would like to mention that since the pandemic, we last year in July, in fact, the legislature approved a funding through CRF for USCRI, Vermont, and ALV in support of case management and other activities, and enabled us to provide that, support to families who were impacted by COVID-19. What I would like to stress is the importance of sustained funding for our two agencies so we can continue to provide health services, mental health services when families first arrive and carry them through. We are the two trusted agencies when it comes to refugee and immigrant, some immigrant communities, not all, but primarily refugee communities coming to Vermont. And then last but not least is a commitment at the highest level to provide linguistic access to language access. It's not an option. It's the law, and all agencies across the board need to write it into their budgets. There has to be a budget line, and both of our agencies have interpretation and translation programs, which are social enterprises, which the revenue supports our programming, so we can provide better support to incoming families.
Thank you. Thank you so much. And please, Amila, share the information in the chat if there's a place where folks can follow up with you if they have further questions. I do I don't want to speak for the governor, but I know there was a budget request for additional CRF funding for this year for those programs that you mentioned. So with the legislature on board, hopefully those will come to fruition. Dr. Wetchi, please tell us from your perspective, where do we go from here? What do we do?
Thank you so much. I think Dr. Mercedes Avila said many things, but I'm gonna add something. What things need to change? I said that health equity in Vermont needs actions. One, involving leaders in minorities community in all levels because they trust on their leaders, physicians, nurses. And the second recommendations, we need experts to be able to explain Vermont family laws to ensure cultural competency in law enforcement. Three, giving new Americans the opportunity to work at all levels could help to increase the economy and contribute to the development. Four, the policymakers should support the creation of leadership positions in the Department of Health Center dedicated to diversity, equity, and inclusion. And please, one example I say, please don't hire me because English is not my first language. I welcome opportunities to share my experience that help Vermont create a more equitable public health system. And I'm gonna conclude, in 1966, Dr. Martin Luther King ad-libbed a line in speech in Chicago to the Medical Committee for Human Rights, saying, all the forms of inequality, injustice in healthcare is the most shocking and inhuman. Merci, Aksanti Matondo.
Merci, thank you so much, Doctor. Dr. Bose, over to you.
Yes, so thank you again for this question. I want to emphasize what the previous speakers have said, especially I think Mercedes and Dr. Wetchi's comment about, especially Mercedes' comment about looking to local communities and working with them, not on them. And certainly universities are particularly guilty of this. But one of the things I've always been struck by in looking at refugee resettlement in Vermont, but across this country as a whole, I would say in other places as well, the kind of the de-skilling of immigrants, the wasting of human potential, capacity. You don't have to reinvent all sorts of things if you simply build on what is already there. And to her point about looking even locally, I think it's great that my university builds programs to recruit students from Boston and New York and Washington, but it would be great if we did more of that locally as well. And so I think not wasting those, that kind of potential is, I think, really important. And to Amila's point about funding, again, if you were to ask me, like, what are some ways in which, you know, as Amila pointed out, we're looking to rebuild this system that has been systematically dismantled in all sorts of different ways. But we don't need to rebuild the things that didn't work as well. You know, we can rebuild it back better. And one part of that is to provide more stable funding. In the case of Vermont, I have to say, you know, I serve on a number of federal panels and funding panels and things like this. And I'm always struck by how little Vermont goes after some forms of funding that I think we could go for. But more to the point that I think that there should be more federal funding and there could be more state funding that is really put into the communities that by and large I have found to be pretty supportive of resettlement, but it could be done much better if there were more and more stable funds that were put into place. So build on the excellent work that's already here, and don't force people to recreate it all the time. That's what I'd say.
Thank you.
Tato.
Yeah, Tato, over to you for a last word.
All right. So I think being the last person, the good thing is that everybody says everything, then you don't have a lot to say, right? So I would like to talk about commitment to provide culturally specific services to our neighbors. I think that's a no-brainer. That's one thing that it has to be part of the requirement for organizations and departments that are providing services to refugees and communities. And it's something that we can really all work together on because we learn from each other. We are not experts in this work. We learn together as we go. Some of us have just done it for a little longer, that I do believe that if we collaborated more, we formed meaningful partnerships, we can learn from each other and build structures that are adequate to provide services to refugees and immigrants as we come to Vermont. I also would like to talk about housing. We know that there's issue of housing in the Chittenden County in general. That's in my mind also tied to the lack of transportation, to access to transportation where people can choose to live in other towns where housing is affordable. I think spending time in thinking about how the structure of transportation can be improved, access to transportation that can bring people to services, take people to work, and go to towns where people can find affordable housing. I think Vermont can do very well in ensuring that people have adequate housing. We struggled a lot during COVID-19 with housing crisis, but that was not specific to the refugee community. It's only that when it happens, it hits the minority population more than anyone else because we live in multi-generational housing. So I think transportation should be one of, as well as housing, key issues that legislatures should really look into. I have to say that one of the areas where I think support could be brought and in a more meaningful way is within the school districts. We have kids going to school. We just don't want them to graduate. We want them to graduate with good grades that can give them opportunities to access universities, access higher education, and all trades wherever they go. But schools need support in so many ways. Our kids come with little education, but with the zeal to learn. So I think building structures in school districts that support students and set them up to succeed, it's one of the things that can really be looked into. I always say this, that collaboration, we cannot do this alone. And funding, sustainable funding, we work on grants. If it's not sustainable, we have to let staff go. Some of us have to work on volunteer basis. It's not sustainable. Cost of living in Vermont is pretty high. There are models, very successful models that work for the resettlement. We have been talking and working at ALV towards a centralized intake system. It's a system that works beautifully. When people come in, you look at all other service providers where you can support people as they come in by referring them to services that they need immediately. This kind of project needs work. I have done it. I was contracted by the government of Manitoba to do this. It's doable. We implemented the project in 1 year. It can get done. There's also what's community-based workers. We have done this. I have worked in East Africa for 7 years, training community-based workers. It doesn't take for people to go to university to do this work. It's work that can be done even here in Vermont. It needs support. So let us all work together to ensure that we become vibrant members of this community and self-sufficient. Our goal ultimately is for everybody to become self-sufficient. Thank you so much all for listening, and thank you for having us again, Lieutenant Governor Gray.
Thank you so much. And I want to conclude, and I'm sorry that we don't have more time for question and answer today. What I'm going to propose is that all of our speakers, if you're comfortable, share your contact information. So if there's specific questions about your work or how to get involved with your work, that participants be able to contact you directly. Our office, my office, is open to also help with questions or questions about what's happening within the State House and within government, working very closely with the Department of Public Health, of course. I want to end with collaboration, 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 which is what Tato just said. And I think coming out of this crisis, moving forward from this event, we hope that there's more conversation about ending systemic racism, around focusing on equity in public health. I will be compiling the recommendations that came out of this conversation today. We'll make those available. A recording of this event will be made available, but I truly hope this is a first conversation of many to come, of course, hosted by my office, but also within state government, on how we can build on success, some of the silver linings from this pandemic, but also work to truly address equity in public health and equity in different areas as we move forward and work to be a more diverse and welcoming Vermont. So with that, I would love to ask all of our participants today to join me in thanking this incredible lineup of panelists. Thank you for your incredible work. I look forward to staying in touch. And I hope everyone will join us in 2 weeks' time on March 8th for our next seat at the table. It is International Women's Day. We won't tell you exactly what the conversation will be, but it will have to do with that very special day. So thank you again. Thank you for joining us. Please stay in touch. And again, to our panelists, thank you for your incredible work.